Hello, everyone. My name is Joe Garasik. I'm the director of the Cardiac Catheterization Lab at Mass General Hospital and the director of Peripheral Vascular Intervention there. Um, Today, I've been asked to speak about renovascular disease, and compared to this talk other years, we've expanded the topic to include some discussion of renal artery denervation. It's a lot to discuss in 35 minutes, so we'll kind of get right underway. So here are my credentials. Here are my disclosures. Um, so the problem of renovascular disease and renal artery stenosis is a common one for the nephrologist. We think of it as a cause of hypertension, and also as nephrologists as a cause of renal insufficiency. It's underappreciated historically, although the advent of more minimally invasive renal intervention and all of the data surrounding that has brought it more to the forefront in the general medicine community. We think of it as a cause of malignant hypertension, and I think this is one of the reasons it still persists, where we should be considering it and perhaps treating it, as we'll discuss. Unfortunately, it's found in many circumstances and appears more or less clinically silent, and the question is what to do about it then, and hopefully this will help answer that question. Um, so let's kind of dive right in. So the disease that is renovascular disease, by and large, is an atheromatous disease. This is atherosclerosis in the aorta that crawls into the ostia of the renal arteries, if you will. If you see vascular disease further downstream in the renal arteries, it tends to be something else. And in particular, it tends to be something like fibromuscular dysplasia in the mid to distal segments. Here you can see the typical beads on a string appearance of FMD, and this sometimes does need to be treated, usually for purposes of helping to manage hypertension, and it differs somewhat from atheromatous disease. Atheromatous disease requires stenting, where FMD can by and large be treated with balloon angioplasty alone. There are other sources that cause abnormalities in the renal arteries. Polyarteritis nodosa, an inflammatory arteritidity, tends to cause aneurysmal disease. Here, a large splenic aneurysm related to PAN. Hard to actually show you a good example of this in the renal arteries. It tends to cause microaneurysms in the more distal intraparenchymal renal vessels, but is really not the topic we're here to discuss today. People who have radiation in the midline that crawls down into the upper abdomen can actually have some influence on the renal arteries and have accelerated athero. Takayasu's arteritis, another arteritidity that can involve the medium-sized branch vessels of the aorta in the upper extremities, but also in the mesentery and the renal arteries. And the treatment here is to focus on knocking down the inflammation first and foremost, and then if one needs to, potentially treating percutaneously. Pretty uncommon. So I won't speak to an august group of nephrologists about renal physiology, but the simple plumber's view is it's really this stenotic kidney that's hypoperfused that ramps up the renin-angiotensin system in ways that you understand very well, and ultimately results in aldosterone release, vasoconstriction, and sodium retention, which presents as the clinical syndrome that we see of hypertension and at times volume retention in renovascular disease. And we'll talk a little more about that when we talk about transplant renal artery stenosis. Making the diagnosis is primarily about recognizing the clinical clues that are described here. I would highlight the importance of noting atheromatous disease elsewhere in the body that should raise your level of suspicion for renovascular disease. This idea of diastolic dysfunction or LV failure out of proportion to LV dysfunction can be a presentation of renovascular disease. So being suspicious is really what it's about in making this diagnosis. When we talk about other modalities, not just clinical for making the diagnosis, yes, the clinical syndrome, but the other modalities include serologic markers, and usually we're talking about serologic marker nowadays still, which is serum creatinine. We all know that you can have a pretty significant change in renal function and GFR without a dramatic change in one's serum creatinine. So this can be insensitive, unfortunately. Duplex ultrasound is an excellent modality, but it depends upon having an operator and a reader who are very skilled and experienced, and it's also partly dependent upon the body habitus of the patient. Captive prorenal scanning is something we really don't see much anymore. It was plagued, unfortunately, by false negatives, particularly in people with bilateral renovascular disease, and is really rarely used nowadays, even to assess the physiologic significance of a noted renal artery stenosis. MR angiography has gone somewhat by the wayside, partly because of the drop in, let's say, popularity and concerns related to gadolinium contrast agents. We know there are non-gato contrast agents, but I would say nowadays we probably do more CT angiography as our axial imaging. I think the problem there, of course, is the use of contrast, and in patients with renal impairment, this can be of some concern. Additionally, heavily calcified vessels can appear highly stenosed when they're in fact not. So even in CT angiography, we have some false positives and overcalls, but usually not false negatives. So if something is pretty clean by CT or MR, the odds are it's patent. And then contrast angiography, which we'll talk a little bit about. So again, with the concern about NFD and nephrogenic fibrosing systemic sclerosis, MR had sort of dropped off the radar. Here you can see the kind of data that you get from MR on the left-sided panel and from actual invasive angiography on the right-sided panel. And I show this to say that axial imaging is still useful in this disease and diagnosis, because it not only gives you some idea of the degree of renal artery narrowing, in this case, a lone kidney with significant ostial renal artery stenosis on the right, which you can see here. But additionally, it shows a very hostile trip from the femoral artery up to some quite diseased iliacs and a quite diseased infrarenal aorta. And this is great for advising the patient on the risk of the procedure and planning the procedure. So for example, one might come in from the radial artery instead to try to avoid all of this unpleasantness lower down. So while it's good that we still have good old cherry options like renal artery duplex, we've lost something if we don't use axial imaging. Here an example of a high-grade renal artery stenosis that's been incubated and has a peak systolic velocity of 429 centimeters per second and an end diastolic of 167. We look at this and renal to aortic ratio greater than 3.5, greater than 4, as suggestive of significant renal artery stenosis. I would say that when you get into the range of 300 or above for a peak systolic velocity, then you're more likely to run into renal artery stenosis that you'd be interested in and perhaps even consider treating if the clinical circumstance was right. So who benefits from intervention? Does anyone benefit from intervention? And I would say that there's a whole mass of data looking at this that predated the randomized data that we'll get into here. And the bottom line is that there was considerable data to suggest that revascularizing the kidneys was a benefit. People seem to have improved blood pressure control. The renal function may have been stabilized. And so there was enthusiasm for many years for intervening upon renal artery stenosis until we got more randomized data and actually had patients to compare to who had not been treated with renal intervention, but did have aggressive medical therapy. And this is an important part of not just these renal interventional studies, but also, as you'll see subsequently, the studies for renal denervation. We're having a control group and using truly randomized data to make decisions actually turns out to be important. So here's kind of a smart study from quite a while ago now, again, prior to the randomized data that we got. But the bottom line is that this used 61 stenosed renal arteries in 31 patients. All of the patients had quote unquote global renal artery stenosis, which is to say bilateral, severe, or unilateral if they only had one kidney. They had significant renal impairment in many cases, and they were treated with balloon angioplasty and stenting, which was a fairly contemporary group of patients receiving a contemporary intervention. So fairly real world. And what they found was that blood pressure improved 170 to 148 post-intervention. As I'll show you, the reciprocal slope of serum creatinine also improved to suggest improving renal function or stabilization. And there was rare restenosis and stabilization of pole-to-pole renal dimension. So this seemed, fairly suggestive of the benefit of renal intervention. Here are sort of the three groups. This is the reciprocal of serum creatinine. So as creatinine went up, the renal function, this reciprocal was going down, down, down in these three groups. And then the time of intervention is this up and down line right here, and beyond it, you see the trajectory of renal function. So post-stent, the reciprocal creatinine either improved, suggesting improving renal function, stabilized as in the middle panel, or continued to worsen, but at a less severe trajectory, using the patient as their own control, but it was suggestive of the idea that there was some benefit being gleaned from renal intervention. So around the same time, out comes what's called DRASTIC, the Dutch renal artery stenosis interventional trial. And basically, this looked at 106 hypertensive patients with renovascular disease that could be unilateral or bilateral. They, by and large, did not have much in the way of renal impairment, and renal artery stenosis was defined as anything greater than 50% stenosis. So the key here is that you could be enrolled in this study if you had a 52% unilateral renal artery stenosis. And as you'll see, this is a negative trial. And why was it a negative trial? Well, it turns out that intervention upon people who have essentially non-severe renal artery stenosis doesn't seem to do anything good for the patient. There are no positive outcomes. It doesn't seem that we're necessarily heading things off at the pass, but the truth is that this was a relatively short-term 12-month follow-up. So it's possible that there were people having renal interventions, and it's possible this kept them from going on to have more severe renovascular disease down the road, but we don't really have that data to speak about. The bottom line is, in the near term, the blood pressures were comparable in both groups. The angioplasty group was on fewer medications, about one, than the medical only arm, and the renal function was similar between groups. And so, in essence, this was read as a negative trial, but of course, there were some nuanced improvements suggesting perhaps an effect of renal intervention. But as I mentioned to you, A, we were doing interventions on probably non-severe renal artery stenoses. B, there was a significant number of crossover patients from the medical to the angioplasty arm, and the data was presented on the original intention to treat, which kind of muddies the waters. C, there were no stents placed here, so this was a balloon angioplasty study, and I can just say, generally, to achieve a good physiologic result from your intervention, stents are the way to get there. They do avoid the elastic recoil and the bulky plaque from sort of prolapsing back into the lumen and resulting in restenosis, and they probably are necessary to glean the full benefit from renal intervention. Also, excluding patients with significant renal insufficiency is perhaps not what we would shoot for. We'd like to exclude patients who have, for example, bad diabetic nephropathy or other sources. But just because someone has renal impairment, not only should we not exclude them, but they may be just the types of patients we're interested, because we want to know if we can stabilize things or improve things by intervening on their renal arteries. So the next trial, which presented randomized data in this regard, was Astral. Astral was conducted overseas, and again, was a trial of unilateral or bilateral renovascular disease that was atheromatous. The physicians were asked, the clinical physicians were asked, well, do you know what to do with this patient's renovascular disease? Do you believe you know that it should be intervened upon or not intervened upon? And if the clinical doctor said, geez, we're not sure what to do with it, then they could be randomized to either a revasc or a non-revasc strategy, both with a medical treatment involvement. I will say that this is a bit strange, because if we truly knew who to treat with renal intervention, we wouldn't be doing these trials. So it's odd to accept people because we believe we have preconceived notions about what the right thing is to do. But nonetheless, the other thing that came of this trial is a significant number of people were actually enrolled who had what we would consider to be non-severe renal artery stenosis. So again, up here in the 80% or so range, where one could kind of go on the assumption, okay, this is probably physiologically significant. there's these two groups, but there were quite a few people down here. So the average percent renal artery stenosis was 76%, and there were a fair number of people that had fairly clearly non-severe renal artery stenosis. There were no translesional gradients measured or anything else of that variety to prove to us that these lower values were in fact significant. So this, unfortunately, again, muddies the waters because those more modest renal artery stenoses are not the ones that we would intervene on normally, and including them in the results here, unfortunately, will dilute down any result that might show a benefit or lack thereof from renal intervention. Um, Another interesting thing is that only 82% of those subjects in the revascularization arm actually had revascularization. There were quite a few who either were attempted and failed or not attempted at all. Again, kind of confusing the results. And there was some crossover in the medical arm, 4.4%, who actually had intervention. The other thing that was curious is there were a fair number of complications from these interventions, and that's odd. It makes you question the experience level of the operators, that they're having embolizations and occlusions and perforations. Those are very rare complications, certainly far less than 1% likelihood of happening with a renal intervention. So it does make you question how these procedures were performed. So you know where I'm going here. Here's the serum creatinine over time in the two groups, fairly superimposable out to 48 months. Here's systolic blood pressure over time. Again, looking perhaps a little bit better for the revasc arm up front, but then really crossing each other and no significant difference there. So Astral was negative, Drastic was negative. And then the next up to bat was the Coral trial. And Coral was meant to be sort of the best self of these randomized trials, with PIs who were an interventionalist and Lance Dworkin, a nephrologist, really trying to get at the question of, is there any benefit to be had? And they started out very strong, and they, were looking for greater than 80% renal artery stenoses, or if there were lesser degrees of stenoses, they had to have a significant gradient across the lesion. They were looking for significant systolic blood pressure on at least a couple of antihypertensive medications. They were excluding people with marked renal impairment, which is reasonable, fibromuscular disease, shrunken kidneys, etc. It all looked pretty good. And they were looking to use antiplatelet therapies, ARBs, possibly a diuretic, and then an amlodipine, atorvastatin combination as their kind of best medical therapy for these patients in a fairly standardized way. And what's interesting about this study is they had a heck of a time enrolling, and it may be because these patients are hard to find, but it also may be because, again, by and large, clinicians had an idea that they understood what to do with these patients. And so people tended to be reluctant to allow their patients to be randomized. So you can see here out of 5,322 people who were actually screened, only 947 ultimately were randomized, and there were about 450, 470 in each group, medical therapy versus stenting. So this was a very small percentage of all the people that were found to have renovascular disease, some dropping out because they didn't have significant renovascular disease. And you can see up here, 801 ultimately just declined to participate, or 200 of them withdrawn by the physician. Were those the ones with the kind of worst renovascular disease who might have gleaned the most benefit? That we don't know. So the primary outcome here, I'll show you. It's also notable that really a minority of people started out with the target degree of hypertension, 25 and 29% respectively in the stenting and medical groups. There were more people with renal impairment and less people with hypertension, if you will, and the average degree of renal artery stenosis was 67%, which again is really generally not severe renal artery stenosis, kind of more moderate. And additionally, most patients didn't have global renal artery stenosis. So 80% and 84% respectively did not. So this is a trial of moderate renal artery unilateral renal artery stenosis in people with renal impairment and modest hypertension. Um, and unfortunately, that's not what we wanted to know, right? But here's the primary composite endpoint: death from cardiovascular renal causes, stroke, MI, hospitalization for heart failure, progressive renal impairment, or need for renal replacement therapy. And what came of this? Well, pretty much a wash. Each group around 35% on that composite endpoint with a non-significant uh, p-value, and all the sort of subgroups here pretty comparable as well. So a negative study. The number of medications in the medical therapy and the interventional arm both went up um, at the end of the trial. So basically, if you start to think about hypertension and renal artery stenosis, you ultimately end up working harder to improve blood pressure control in your patients, and you can be successful at it. Here's the change in systolic blood pressure in the two groups, dropped by about 15 or 16 millimeters of mercury. So, um, here's the kind of 5-year follow-up data on event-free survival. It is interesting that when you get out to 5 years, the curves do diverge a bit, but really not statistically significantly so. But it is interesting and perhaps hypothesis generating that despite the fact that these were non-severe renovascular interventions in patients with modest hypertension, is it possible that there was some longer term benefit? I don't know. So the conclusions for CORAL are that most patients had non-severe renal artery stenosis. Most did not have severe multi-drug resistant uncontrolled hypertension. Most of them who were screened were ultimately not enrolled, so we don't know how applicable this would be to your general population. And I think ultimately this was a difficult study because it's hard to imagine that anyone's going to invest in another CORAL like trial anytime in the near future. And this is the data we're probably going to have to live with for quite some time, if not for good, in renovascular disease. And it's unfortunately confusing because none of it really answers the question of what to do in the patients in whom you are most interested in treating renovascular disease. So who is that? That's the truly multi-drug resistant hypertensive patient with renovascular disease. It's the patient where you've really worked hard on medical therapies and they're still uncontrolled or intolerant of medications. It's the people with bilateral severe renal artery stenosis. And even if they have significant renal impairment, if that correlates with the progression of disease, you might be interested in treating that patient. It's the patient who comes in with recurrent bouts of pulmonary edema and malignant uncontrolled hypertension, where you say, we have to do something to break this cycle, and we've found severe renovascular disease. And then it's the FMD people, right? They're not included in any of this, and we know that treating FMD with balloon angioplasty is very safe. It's well tolerated, and ultimately it does improve blood pressure control, but they're not part of these studies. And then finally, an interesting group, the group of patients with transplant renal artery stenosis, where everyone has kind of hung their hat on the transplant and used a whole lot of effort and investment to try to, get this patient treated surgically and back on the road of improved renal function with a transplant. And yet they can develop inflow stenoses in the iliac or in the transplant renal itself. So here's what that looks like. This is, an anastomose, usually in the external iliac artery, both the artery and the vein you can see here in the iliac vein. This is reminiscent of the sort of uh, uh, kind of double clip model. So basically, this is a patient who essentially has one kidney and one clip, which acts like two kidneys and two clips. In the two kidneys, one clip model, people can be hypertensive, but they tend to have a pressure natriuresis, and so they tend not to be volume overloaded. Whereas your transplant renal patients are really kind of one kidney, one clip. Yes, they can be hypertensive. Yes, the renal function can look to be worsening, but they also tend to come in edematous and congested with volume overload. And so when you see that patient post-transplant, that's a person to think about. Here's an MR imaging in somebody with 2 transplant renal arteries going to 1 kidney with significant transplant renal artery stenosis, and you can see a patent iliac. We can use time of flight MRA to image these people and get some idea of what's going on in the iliacs and the transplant renal. We can use duplex ultrasound to look here at the transplant renals as well. And this is a significant population nowadays that we need to think about renovascular disease and treat, I think, where it's seen. Restenosis can occur with renovascular disease. Here you can see a cross-section of an artery that's been stented, and this business in here is smooth muscle proliferation, which causes stenosis. How often does that occur? Well, something in the range of 20%, we know that it occurs, but that doesn't necessarily mean that in 20% of cases it is actually physiologically and clinically significant, where it seems to be much less common. It turns out that the likelihood of restenosis depends upon the size of the vessel. Bigger vessel, lower rate of restenosis. Smaller vessel, higher rate of restenosis. So treat the big ones. We've looked at a use of a variety of different modalities to reduce this risk. And so far, what we've come up with is not so much the use of drug-eluting stents, but actually these PTFE covered stents. Again, not a randomized trial, but looking at the rate of re-restenosis when you treat restenosis with covered stents, and the bottom line is it's very, very low to nil. So nowadays, this is our management strategy for the re-restenotic renal artery. And then finally, just to kind of get involved in renal denervation, because I think you're going to start to hear more and more about it. Generally, we're presuming in the renal denervation patient that we're not talking about renovascular disease. But I think you'll probably run upon a variety of patients that should be screened for renovascular disease. And if and when they don't have significant renovascular disease that might help in their blood pressure control, you're actually going to kind of turn your mind to the possibility of, well, might they be a candidate for renal denervation? So, where does this come from? We know from the 40s and the 50s that there was early surgical literature that said that this was a treatment for essential hypertension and had some evidence of improving patient outcomes by essentially stripping the renal arteries of their surrounding nervous supply. Then over time, we've become, better informed about the importance of blood pressure control, worked hard on guidelines to get everybody on board with doing just that, campaigns to let patients and doctors know how important this is. And then in parallel, all the catheter-based technologies really took off in the coronary circulation, in the peripheral vascular circulation, carotids, renals, lower extremities, you name it. And then eventually, we found out that we could denervate a kidney without actually ever cutting anybody open. And so that sort of changed everything. So the early catheter-based RDN trials really looked at multiple different technologies, radiofrequency ablation, the use of ultrasound energy, and even the injection of neurotoxins into the wall of the vessel to actually ablate the surrounding renal nerves. This was looked at in a whole host of non-randomized observational studies, and almost across the board, these studies showed that ablating renal nerves ultimately ended up resulting in improvement in blood pressure, or at least was associated with that. But these were non-randomized trials, and so in order for these companies and technologies to get FDA approval, they had to present some randomized data. And in particular, the randomized data is sham-controlled data. So actually procedures where you go in and pretend to do a denervation procedure and then follow afterwards and see what the outcomes were. So these were randomized, blinded, sham-controlled procedures, the first of which was the Simplicity Hypertension 3 study. This was using radiofrequency ablation technology, and it ended up being a negative study, and everyone scratched their head and said, geez, how could this be? And what we've come up with since then there are a variety of kind of potential issues at hand with Simplicity. The first is it could just be an ineffective technology. Maybe it just doesn't work. But we knew that if you looked at pathologic specimens and you used radiofrequency technology, you could then go in afterwards and find out that, yes, in fact, you could reach to the the nerves and you could ablate them and do a pretty effective job. So how did this happen? Well, one of the things we learned is that it's a technique related issue. It's about doing actual 4-quadrant ablation. So what you want to do is not just hit in one line, for example, on a renal artery and thus the nerves behind, because all of the other nerves that you're not kind of reaching are maintained, and so they can still message and do their job, that's related to regulating blood pressure and can be causing accelerated blood pressure. And so it turned out that having a circumferential ablation was almost certainly important in this case. We also found out there's probably a best place to do the ablation. So it turns out that things had been more focused around the ostium of the renal artery, but it turns out the further you go in, the closer the nerves are to the lumen of the renal artery. And so doing ablations further out, even in the initial branch renal arteries, might have resulted in more effective ablation. Um, Patients were having med changes during these procedures, and so this was muddying the waters. The Hawthorne effect is just the concept of observing the problem gets everyone focused on it. And so again, these patients were getting non-medical and sometimes medical therapies for their hypertension in inequitable ways. And so this was sort of slanting the outcomes towards the sham control group. There were probably some patients selected that were more of the low renin variety, which are not going to respond as well to renal denervation. And also there was some time spent figuring out whether ambulatory blood pressure readings might actually be more reflective of real life than office blood pressure readings. And so after this, the trials tended to include both, or certainly at least ambulatory readings. So what came of Simplicity 3? Well, at the 12-month data, the blood pressure was down about 7.5 millimeters of mercury, and at the 36-month data, down 15.6 versus sham. So even though out of the get-go, this did not reach statistical significance, there was some pretty good data to suggest something positive was going on. The subsequent Global Simplicity Registry, again, same technology. You can see the change in systolic blood pressure from 6 to 36 months, regardless of GFR, seem to improve, but these are modest improvements in systolic blood pressure. So what the company that makes this catheter did is they ultimately redesigned it into a spiral-shaped catheter with multiple electrodes that actually hit the renal artery and thus the renal nerves in a circumferential fashion, so they can ablate kind of all the way around with one treatment. And this redesign resulted in some more randomized sham-controlled trials, the real business. And what did you see? Well, at follow-up, office blood pressure was down about 8 millimeters of mercury. And if you looked at 24-hour blood pressure monitoring, it was down about 5 millimeters of mercury versus the sham-controlled value. So there was some benefit, but it was modest. These are, by the way, patients that were off meds. So this is kind of modest hypertension, 1 or 2 medicine hypertension. If you look in the next trial, the spiral hypertension on med trial, these were people with more refractory, difficult to control hypertension, followed out to 36 months. And you can see that 24-hour mean, nocturnal, morning blood pressure in the systolic and the diastolic measurements all seem to improve significantly with denervation versus sham. So there did seem to be a benefit to the use of this technology. A second technology, this is a balloon-based technology. In the middle of the balloon is an electrode that emits ultrasound energy, and that ultrasound energy can go deep into the wall of the vessel, about 6 millimeters or so, and that can actually knock out most of the renal nerves that are in the vicinity and that are reachable, which is the majority. Pretty simple to use. It's a low pressure balloon. What kind of data do they have? Well, same kind of business versus sham control, 2.2 millimeter drop in more modest off medicine patients versus 8.5 with ultrasound-based renal denervation. The TRIO trial was a 3-med trial. So these were patients on multiple medications, also drop about 8 millimeters of mercury in the ultrasound trial, and Radiance 2 off med is again a more modest group of hypertensives, again down about 8 millimeters of mercury. So benefits all the way around. Who shouldn't you do renal denervation in? Kidney transplant patients, those with severe renal insufficiency, and at present, probably lone kidney patients, but not so clear because they wouldn't have been included in these trials. No data on the hemodialysis patients, not for the fibromuscular dysplasia patients, and not for patients who have other secondary causes of hypertension. So these need to be investigated for first. Who do you consider this in? Those who are on multiple medications, who are still refractory, those with med intolerances, those who have end organ damage and high cardiovascular risk, and have difficult to control high blood pressure. This is how it's done, and it's kind of straightforward, which is basically if you have a secondary cause of hypertension, you go that route first. If you have only primary hypertension, you kind of go down this pathway of making sure that their blood pressure is uncontrolled, that they're adhering to their meds. Do they have accessible vessels, which you can image by CT angiography? Nowadays, avoiding those with marked renal insufficiency and then referring them for intervention. So the take-home messages for RDN, which is a burgeoning field, is we have early surgical proof of concept, sham-controlled data that confirms the efficacy of these therapies, and there are more being developed. It turns out that the people with the worst hypertension probably benefit the most from RDN, so think about it first in them, but also make sure that you've ruled out secondary causes. Don't send your patients with RAS and with adrenal tumors off to renal denervation procedures. So here are some summaries that you can read offline. Again, offline, you can go through a few of the questions here for your interests, which are focused around the things we've discussed today. I hope this is useful, and thanks so much for giving me the opportunity. Bye now.